you Paolo Pelosi from Italy. He is a good expert in everything about how to ventilate morbid obese patients, but nevertheless I asked him to a little bit broader because these items are sometimes so difficult even for us, and there are surgeons in the room who will keep it in a broader view.
Thank you very much. It's a great pleasure to be here, and we try to make you a short overview of the respiratory problems in obesity, and can be helpful for discussion between anesthesiologists and surgeons, and no conflict of interest in this presentation. I'm coming back a little bit about mortality. This is a very recent study on New England Journal of Medicine showing that really the major improvements that we got in the last years were mainly related to medical pathologies. So we had a major improvement in acute myocardial infarction, major improvement in the survival after congestive heart failure, but we have no major improvement in the treatment of pneumonia, and as you can see also in the condition requiring surgery. And most importantly, if you look at the patients requiring surgery, that even a worsening condition for post-procedural events, infection, and general complications. So, first message is that we did a lot of progress in medical science, but we had major problems in outcome after surgery. And one of the main cause of this is related to the problems after surgery, not during surgery or anesthesia by itself. This is our last study we published 2 years ago. There was a big debate about this study. It's a large study, including patients with different types of surgery, but we found that overall in Europe, mortality was much higher than expected, around 3 to 4%. However, in this study, we did not find BMI as an individual independent predictor factor for mortality. Of course, different types of surgery are at risk. This is just a brief summary about mortality and obesity, and as you can see, there is a trend to an increase in mortality mainly in the very, very obese patients, only when BMI is higher than 40, or when you are really less than 18, but this is not our issue today. Very few patients now like that. So, really mortality is related to BMI, but only if you are in very, very morbidly obese patients, so even higher than 50. This is the first message. The second, however, is that morbidity is progressively increased with BMI. So we have any way to take care of these patients very carefully, because morbidity progressively increases with BMI from more higher than 27 to higher than 40. I was asked to speak talk a little bit about OSA, and I just show you 3 scores that can be used. This is one published by the American Society of Anesthesiology, and this is, you can refer to this study, 2006 is probably one of the best practice guidelines published to date, and it is related to the clinical signs and symptoms suggesting the possibility of OSA, the history of problems related to sleep of these patients, and the presence of somnolence. But more importantly with this recommendation is that this is also related to surgical or anesthesiological issues. You see here that it's not only related to the level of risk for OSA, but also if the invasiveness of surgery or requirement of postoperative opioids are integrated in this course. This is very interesting. It's not only a suspect of OSA, but also possible factors during surgery, or the type of anesthesia, and postoperatively the use of opioids that can increase the risk of problems related to OSA. This is probably the most famous and used questionnaire, is the STOP or STOP bang, and you see here is related to, of course, also the presence or not of hypertension. And this is the stop. Then it was developed, which appears to be sensitivity and specificity very, very high, more than 95%, up to 100%, when they include also the BMI, the age, the neck circumference, and the gender. And this is another study that I suggest you to look at to use this questionnaire. This is another one, sorry if it's difficult to read, but just to take also the last reference, which is this other score, which is very easy because it includes only if you are hypertensive or not. This is related also to what was discussed before, related to the possible presence of heart failure or cardiovascular problems. And then two very easy questions related to snoring and gasping. So, different scores can be used, but if you look at these scores, and then if you look at the complication postoperative, you can see that several studies, this is one of the most recent published, specifically in bariatric surgery, you see there is no effect of presence of mild, moderate, or severe OSA associated with permanent surgical or other complication. So, it's not very clear if the diagnosis per se is a risk factor for postoperative complication, as was mentioned before. And also these are more recent studies showing that you see in different types of surgery, the presence or not of OSA is not associated, for example, for postoperative respiratory failure or other complications. So, the question to me is not if you have more information about OSA or not, which is the clinical condition before surgery. This is a study that was performed by Jean Canet, the Spanish group. It's the ARISCA score. And this is a very nice score to predict the postoperative complication. I will show you the validation of this. And it's very easy to do. You can measure the age, the preoperative oxygen saturation in air. This is very important. It's not usually performed. Respiratory infection or preoperative anemia, and then of course the type of surgery. And if this score is higher than 26, you are likely to develop in at least 30 to 35% of the cases postoperative pulmonary complications. Higher than 45, more or less half the patients will develop this complication, which are related to higher length of stay in the hospital. But what I want to say is that independent of the diagnosis of OSA, the most important, if the oxygen saturation is lower than 92, 93 or not in the air. You can have a diagnosis of OSA, but if this is not associated with a problem related to oxygenation, this is not associated with any complication at all. This is our view. And this was validated by this study, which just finished and accepted on anesthesiology, will appear in a few months, and which we validated this score in a very large population of patients, and this study will appear very soon. You see when they're less than 92, independent of your pathology, COPD, obesity, whatever, you can be very big obese. But if your oxygenation, for whatever reason, is relatively good, you have no problem probably postoperatively. So the most important to me is to measure saturation. So it's the effect, not the diagnosis of what you're doing. And this is a nice study showing that, you see, you can have low risk of OSA or high risk of OSA, but if you have no desaturation postoperatively, in the immediate period, you have no difference in respiratory complication, while you have much more complication if OSA is associated also with recurrent postoperative negative events. So this means that the first message here, of the first part of my talk, is that it's not a problem of diagnosis or not. Of course, you can have a score to have some idea if this patient is high risk or not, but this is important, what is the effect on the patient. So my suggestion, measure oxygen saturation before surgery is one of the most important predictor of postoperative complication, postoperative pulmonary complication, and measure in the first 24, 48 hours postoperatively. If we have these kind of patients, we have to take care of the moment of intubation. This is what happens when we induce anesthesia in normal subjects. You see a reduction in lung volume with very few atelectasis there, or or when you have a obese patient, we have a major reduction in the lung volume with the presence of atelectasis in the most attended part of the lung, as you can see here. You see here the atelectasis and the reduction in lung volume. So it's very important to maintain, especially the patient with eventually at risk of OSA or obese patients, reverse ventricle at the moment of intubation in order to reduce the effect on the lung volume. And we did several studies looking at the non-invasive respiratory support by CPAP or pressure support at the moment of intubation. This is very important to be discussed with the team, as was mentioned before. This is an example, which is a ventilator at the 100 FiO2 with a positive end expiratory pressure of 5 and pressure support at 10 in mask during induction of anesthesia. The patient is induced, so you have by mask, you have apnea, but you have maintained a PEEP of 5 at the moment of intubation, and at this point you intubate the patient. These are major effects. You see here the oxygenation awake at the moment of intratracheal intubation and 5 minutes later. In the conventional intubation, you see that when you induce anesthesia with NPPV, so non-invasive positive pressure ventilation, you have much higher level of oxygenation at the moment of intubation, especially also in patients with OSA, so this makes the intubation much safer. So in case at least not in emergency perhaps, so we have to be a bit more careful, but in elective surgery, bariatric surgery, I strongly recommend non-invasive ventilation or CPAP at the moment of intubation. What about recruitment and ventilation? We learned a lot of things in these last 2 years. This is what happens in obese patients while awake after induction, major reduction in lung volume and atelectasis, as you can see here. If you apply a positive end expiratory pressure, you see you don't get too much, up to 10, 12 centimeters of water. If you apply a recruitment rule, so you apply higher pressure in the lung in order to reopen these atelectatic areas, but you go back to lower level of PEEP, again you have this atelectasis. Only if you apply recruitment and PEEP, you can keep the lung more open during surgery. And this is a fact related to lung morphology. But then we organized a big network. This is the protective ventilation network with Marcus Schulz and Marcelo Gama-Lebreo, supported by the European Society of Anesthesiology. And we started a very big studies on mechanical ventilation. I can present here the data of a big study we will be published in a few days. I will be presented the European Society of Anesthesiology. We look at the effect of PEEP in a large population of patients. But I just show you some big database we have on more than 900 patients, looking at the protective mechanical ventilation, so low tidal volume and a little bit higher PEEP as compared with higher tidal volume, which is the conventionally used alveolar ventilation and lower PEEP. You see that there is a significant effect of protective mechanical ventilation, so use of lower tidal volume and higher PEEP as compared with the higher tidal volume, 10 meter per equal body weight as compared to 6 meter per body weight and lower PEEP. But no effect of PEEP, at least in general population of patients. And you see here that tidal volume is very much related. You see here the tidal volume, milliliter per kilogram predicted body weight. And this is also for obese patients. And the risk of postoperative RDS or respiratory insufficiency. When the tidal volume is higher than 8 of milliliter per kilogram predicted body weight, the risk to develop postoperative respiratory failure progressively increases. So the suggestion that we have now is to use low tidal volume, even in obese patients, according to predicted body weight. And if you look at the effect of protective mechanical ventilation and different scores, we concentrate on body mass. You see that this is effective in all type of body mass. We have less data with patients more than 35. But between 27 and 35, protective ventilation works. We believe that tidal volume is the most important factor to decrease postoperative respiratory complication. PEEP can play a role, probably less than tidal volume alone. We have now launched, and we will launch in a few months, another big studies, another randomized control trial, like the other that we just completed in so-called normal subjects up to 40. This study will include only patients with BMI more than 40. So we have the feeling, or now more data. The tidal volume is very important during surgery to reduce postoperative complication. Peak pain recruitment is much less in patients less than 40, but we don't know what happens in more morbidly obese patients when we are likely to use higher levels of peak. But what the message today is use low tidal volume in whatever patients during surgery. Then we have postoperative period. We have not to leave the patient in this position. So we have always the patient in upright position in the bed. This is very important, and this is probably also related. I was discussing the MDT team before surgery. I think we should have something similar also after surgery, because this is not always accomplished in clinical practice. Physiotherapy, very easy, early mobilization, deep breathing with or without incentive spirometry. We have full of data showing that this is not always absolutely necessary if you have nurses or people that are training the patients to have deep breathing after surgery and stimulation of the gut. We have very few studies, randomized trial, this is one of them, showing that if you apply a very aggressive physiotherapy after surgery, so again you need a team to do that, you may markedly reduce postoperative complication. What about non-invasive respiratory support? Especially in morbidly obese and in upper bariatric or major abdominal surgery or history of sleep apnea, is suggested not only to use a CPAP or positive pressure during intubation, as I showed you before, but also some people during surgery, but we have to see probably this is likely better in more obese patients. But most importantly, after extubation, it's now suggested to use some CPAP, test with the water, or some pressure support in the first 24 hours, not continuously, but at least 3 times a day, and continuously evaluate the saturation rate. Saturation is the most important one. Saturation and respiratory rate are the 2 most important, easy to get at the bedside parameters to be monitored postoperatively. Of course, if you have more respiratory rate more than 30, I would say more than 25, and saturation less than 93, with FiO2 more than 40, of course you need to apply more aggressive non-invasive respiratory support. So again, I want to focus the saturation and respiratory rate should be monitored very carefully in the first 24-48 hours. This is the time in which we can have more complication related at least to complication. We have different systems. You can use the CPAP, Bushniak CPAP, as you see, it's a very easy method. You can get oxygen here. This is the mask with a virtual valve of CPAP, and now they developed a small machine that can help also during the support. Now there are new devices which can be used by the mask, or we use also the helmet in Italy, but can be used also by mask. And you see are very light. This is the oxygen, it's a Venturi system with the entrance of the hair here. This is the additional oxygen if you need an increase in oxygen. This is the PIP valve. So it's very easy to be applied or at the bedside or in the ward. You don't need to return the patient in a more specialized unit if you have some monitoring. And these are other systems that have been developed. You see again, this is the Venturi system with a double line with oxygen and a supplement of oxygen. This is the PIP valve, and eventually the monitoring of PIP within the mask. So this is very important because this technological improvement can make CPAP very easy to be applied in the ward postoperatively, especially in this kind of patients. This is my last slide, which is more or less what Mike showed before. This is not scientific. This is just a collection of data in many studies and in our experience. You see that if patients are recovering, I'm not saying intensive care, but in an environment in which patients can be more carefully monitored, even in the ward, again by saturation, by respiratory rate, and looking at all the parameters that were mentioned before, we are likely to have much less respiratory complications. So easy monitoring in the postoperative period is probably the most important for this patient. To conclude, I showed you that overall in surgery, postoperative morbidity and outcome, especially related to surgery, is an increasing problem in this last year. So this is really a new area that we have to take care. There are different scores to identify patients at risk of OSA, but I show you that this is not the real problem we have to look at probably, because postoperative pulmonary complications are not associated directly with OSA, but with the low level of preoperative oxygen saturation and the postoperative level of oxygen saturation. So monitoring what's happening to the patient is more important than diagnosis by itself. Non-invasive ventilation by CPAP or causing pressure at intubation should be, in my opinion, performed routinely in these patients, at least when communication are not present. We learned just recently that the low tidal volume is very important. No more than 7 meters per predicted body weight is essential to reduce postoperative pulmonary complication. Probably in obese patients, a higher level of PEEP and recruitment can be helpful to protect the lung. And in the postoperative period, we have to take care of the positioning of the patient in the first 24, 48 hours. We need an aggressive postoperative restorative physiotherapy, especially in this patient. This is the only category of patient in which physiotherapy has been shown to be really effective to improve outcome, and non-invasive respiratory support should be used in selected patients, and I show you also very recent new technological advancement that can make CPAP very easy to be performed at the bedside and in the ward. Thank you very much.
Are there any questions from the audience? I have two questions if the audience don't have questions. The first question is, what about physiotherapy in a routine post-operative patient? You and I both come from an intensive care background.
Yeah.
Intensive care nurses, they like their patients to be nice and comfortable, lying nice and flat. Our obesity ward nurses know the most important thing is to get the patient up, to prod them, get them sitting out in the chair, get them sitting up, and mobilise the patient aggressively.
Yeah.
And we tell our patients beforehand, do you really think that it's the respiratory physiotherapy, or it's just physiotherapists getting patients moving that is so important here? That's my first question.
I think that I just showed these three items because from what we look at the literature, appears to be mobilization, which is not respiratory physiotherapy per se. It is part, probably, of course, but mobilization, and we don't know if incentive spirometry or deep breathing is so important. I don't think so much. I agree with you that mobilization is the most important. Then, incentivation of cartilage, inspiration perhaps they play a role. So mobilization is very important in these patients. Related to the fact in which patients, I'm not suggesting here to perform physiotherapy in all patients, because it would be impossible and very not much cost effective. What I think we should need to identify patients at risk, I just show you a very simple score, the ARISCA score, that now we validate in a very large population of patients. Very easy. It will not be perfect. It can be improved, also adding complications during surgery, especially hemorrhage. In the group of patients which we are very likely to have complication postoperative, probably in this patient we have to be more aggressive. I think so more rational, using also the MDT so through discussion in some way, can improve also to select those patients who will benefit physiotherapy postoperative.
Any comments from anyone in the audience like to make any additional comments on that one? Okay, I'll save my second question for afterwards. We need to move on. It's time is moving on.
Yeah.
Okay.
Okay, I will move on. But actually, just a short comment on the saturation. Keep it short. If the measurement is done and the patient is laying flat or sitting up, or, and that's something I now do always, I ask my patient to take deep breaths, at least some physiotherapy. If you see then a value of 90, rising to 98, frequently even 100, I'm sure that this patient had atelectasis, but he's able to open that. But how does that fit then in the prediction group?
This is a good question. Usually this measurement in overall was suggested to be performed more or less with the patient lying in supine position. But in obese patients, we know that some of them, especially obese, they can have some trouble. So this can be anyway performed in a big chair position. The question overall, I think, is that if you have some desaturation, not desaturation, but low oxygen saturation, less than 93, 94, in whatever position you are, this is, at least our data show that this is one of the most important predictors of possible complication post-operatively.
Okay, I take the chair again. And I think Jan Mullier needs very little introduction. He's president of the European Society for Preoperative Care of Obese Patients. He's organised these meetings and these sessions for several years now. And Jan is going to talk to us what we should know as anesthesiologists to improve care for our patients rather than the other way around, which was the first part of the session. So we talk about optimising the laparoscopic workspace. Jan, thank you.
Yes, okay. Well, this is something I'm working on already quite long, so I will skip some parts, but try to give you the idea what we should do, of what we as anesthesiologists should know, how to improve and help the surgeon. That's a little bit what it is all about. The fact is that this is about neuromuscular blockade. The anesthesia itself was assumed to be now helpful for the surgery. It didn't be. The introduction of relaxants, we thought this will be helping. Anyway, we couldn't have D-block because we didn't have any reversal. Now that we have a reversal agent, still we are not giving sufficient D-block or sufficient space for the surgeons. Why is that coming? Well, there are even studies who are showing that we don't need to use a D-block to improve the surgical workspace, but most of these studies are in gynecology. They are in the lower abdominal space. These patients are not morbid obese. And as you look in the papers, they were telling even that the patients with a high pressure to start, that putting the trocar was difficult, but this was the job of the surgeon, so we wouldn't care about that, and we will continue with not giving D-block. This actually is a system that happens frequently, and I love to just show that a little bit on what is going on. Is that the surgeon is complaining, I have no space, they cannot operate. Or we say, well, look, that's your problem, everything's fine at my side. And even if the surgeon by himself is already increasing the pressure up to 18, we are getting upset too, because this patient will not tolerate a higher pneumoperitoneal pressure. But then we said, well, look, if you will better experience, there will be no problem. And then the surgeon has no option or to change to laparotomy, even requesting to give more neuromuscular blockers. And then we can compare and say, well, look, last time this was no problem and we were at the same level, so why now this time? And so what it all comes down is that there is a huge difference in the patients. And the surgeon can note this difference already when he starts the laparoscopy. If he sees that he needs then high pressures, probably this is a patient where it will be difficult to do a laparoscopy. Certainly when the patient starts to move and to breathe again, we're getting around troubles. Now, what the surgeon needs is initially pressure indeed. He needs pressure, so not to get in this situation, because he needs to press the trocars inside, and he don't want to hurt anything here. So he needs some distance, but at the same time pressure. But once all the trocars are in place, it's only volume that he requires. And once he has the volume, the pressure doesn't matter. So that's why most surgeons start at like 15 or something like this pressure. But then we should be alert and say, look, if it is not possible to go to a lower pressure because the volume is sufficient, and then we will have less troubles for giving anesthesia, the patient will have less pain. But is this possible? Well, I'm just giving frequently this slide, it's an old slide, nevertheless it explains everything already. We have patients where we have a volume of less than a liter, we have patients where we have a volume of 10 liters. And this is just the patient different. So every patient is different. So, and if you have a patient on the left, it's a problem. Even if you give deep neuromuscular blocker, it will not work. If you have a patient on the right, it's great. We don't need neuromuscular blockers at all. Can we predict these things a little bit? That's what we then see initially. So we as an anesthesiologist have to look. And if we see that the surgeon only has 1.2 liters and you already have 20 to get something in, well, this is such a patient with a problem. If we see here already 7 liters at his first insufflation, with a pressure of 14 or so. This is great. This is a patient where we can reduce the pressure. So just to look into these values give you already an enormous amount of information. Most surgeons know that, although they will never communicate that back to us, telling from, hey, this is the patient where you will have to do something more, and this is the patient where we can discuss together what we will do. Or I lower my pressure, but you keep then the D block, or I keep my pressure and you can lower your block. So that's a little bit the possibility. Now you can measure more, and if you measure abdominal compliance, you get more idea what is going on. With this you need only the PV0, the starting pressure, and the compliance of the abdomen, a few points, and you can construct that. We'll go now in detail. There's some determinants for both, but this, and I bring in another scoring system that we now use with a few easy questions. Based on that, if you answer just yes or no, this scoring system translates down here in something like a high score means a large abdomen, a small score means a small abdomen. Now these questions are quite simple and obvious. Just look here, and we know that women with more children already a long time ago will have a larger abdomen because the compliance is bigger. Those who've had laparoscopy in the past have a larger abdomen. The more obesity there is, the smaller the abdomen, certainly when it is a central obesity. And an important aspect is also the amount of weight reduction. So if the patient is able to have some weight reduction, then we will gain a lot. For me, the absolute body weight is not important, but it's the fact how much weight the patient is below his maximum weight ever. And if this is substantial, more than 10 kilograms, there will be always less problems in workspace. Now this is a scoring system you can download here for free. It's an Excel sheet. You can just use that, and at least preoperatively, this is for me also a guidance to tell, hey, if we are ending with a small number like 2 or 3, this is a patient where we will request absolute to lose body weight before going on for surgery. Once you are at 6 or higher, it's not that problem. But again, it are these same patients, the male with the intra-abdominal fat. That's the group where these problems probably are bigger. The 3 points measurement is something that we do here. You see here me standing at the insufflator at the start of the operation, and I just stop the insufflator at 1 liter, 2 liters, 3 liters, or half a liter, and I just take a notice because this pressure goes up and down with respiration, and with this I get an idea of the abdominal compliance and of then the correct setting of the abdominal pressure during the procedure. We can make then a calculation to it. This is, again, a free, available, downloadable Excel worksheet in which you just put in here the figures of the volume and the figures of the pressure, and the computer calculates immediately what the 2 values are, and he will be suggesting if you want 3 liters, you need this pressure to proceed. And he's also telling here, this is actually a small abdomen, you need 15 to get to the 4 liters almost. This helps, you don't need to calculate that each time, but it helps to understand what patient you have in front of you, and actually it helps to get a certain pressure. And it also helps to understand that sometimes the patients on the left with a very small abdomen, even with a D block, there will be not sufficient space. And then we can tell our surgeon and say, look, nevertheless I do whatever I can, nevertheless we will have trouble. And then it's not just you not giving sufficient nerve muscle block, because you were giving sufficient, but it's the patient himself who is different. And that's very important to know. Neuromuscular blocks have an effect, they decrease this line, so you get a little bit more space, and depending on the compliance, the effect is large or is smaller on what you can gain by doing so. There are other things, and again, the B chair is not only great, as we heard already, for pre and post-operative, it's also great during the surgery, because in the B chair position, you have an elastin that is smaller, or a compliance of the abdomen that is bigger. You get 500 cc's extra space for the laparoscopy at the same pressure. And this is fantastic. If you keep your legs down, as we did a long time ago, but the patient was even sliding over the table, we have more troubles, have less space in the abdomen. It's not that much, it's a little bit, but it helps. We can well measure them where we are in the depth for the neuromuscular blockade, but the most important thing is we are measuring on the tongue, and the surgeon is interested that the abdominal muscles are relaxed or the diaphragm is not really moving. And this is one of the problems. If we go down a sufficient block, well, we can change the scenario and having even a surgeon who is happy that he can now work and have sufficient space. That's what you can see here. In the patient, 1 liter, 2 liters, 3 liters, without neuromuscular block, you can do that. But you have a pressure of 15. And now we go to a neuromuscular block and we gain 1 liter for the same pressure. Now, if the patient starts to breathe against the ventilator, well, the insufflator will not release any gas. It's great because then there's no danger that you suddenly will touch an organ, but then you will get very high pressures. The pressure will rise dramatically. And the surgeon will have, well, limited or no view if there's a leak and all the gas is coming out immediately. That's what you can see even if you have measured abdominal compliance. When you have an active contraction, the compliance gets extremely small. So this is something you have to avoid absolutely, because then there is no space at all. You see now we have less than half a liter at the pressure of 15 in the abdomen. And so this is a difficult situation. This you can avoid by giving sufficient anesthesia or by a D-block. Both will work to prevent this from happening. Surgeons can predict a little bit if there will be some troubles. It's the same as our scoring system, saying these are the apple-sized persons, the women have been pregnant, the first laparoscopy, at the maximum weight at the moment of the operation. So these are predictive factors. What we do to improve that is the deep neuromuscular block, the patient positioning. Well, if this all doesn't work, we will go for a higher intra-abdominal pressure. Standardization will help to let the surgeon work in a smaller volume. What we try to do is some kind of overstretching. We do that when there's really a problem and we didn't decline the patient preoperative, something we should have done. Then we use that system to go for a short moment of high pressure for a few minutes, come down again, so at least to allow the perfusion to be maintained and to avoid rhabdomyolysis. Now, surgeons frequently are the first one to notice when our neuromuscular blocker is worn out, and this actually has to do with the fact that we have a problem. We are measuring on the wrong muscle. The diaphragm and the abdominal muscles are a lot more resistant, so we need a deeper block before these muscles will get relaxed. But it is great for us to use that at the moment of the end. If the thumb is reversed, then at least all the other muscles will be reversed except in the neck, because these are even later on, but at least there will be no problem in the force for breathing. There might still be obstructive breathing. And the second trouble is that in the spontaneous recovery, the surgeon will see the abdominal muscles 10 minutes earlier reversing than we will see it on the thumb. So if we still see that the depth of block is sufficient, the surgeon might see, oh, the abdominal muscle is already moving. And we both are right, because we were right because we were measuring on the thumb, but the surgeon is right because the abdominal muscle is moving. So this is the real problem. And we should be aware of that difference in reversal speed of the different muscles. And for that, one of the things I try to do is to use a continuous infusion, because then we will not have that big trouble of being 10 minutes later. Going for a D-block is one aspect, but we'll have to measure it, not just by train of 4, but post-metallic count. And by continuous infusion, you will have some more time. You will not get that trouble of the surgeon seeing this aspect first. So these are the aspects we do for improving that optimal work space. Just shortly, and I have a few minutes left, I will show that we do the leaking test. Leak test is something in which we as anesthesiologists are very important. And so what we try to do is to do an extreme overstretching, as you can see, by a very rapid infusion of a large amount, and a little bit here out of time, so they're not well synchronized, I see. So you see we inject extremely fast, and then you get a blowing. If you do that slowly, everything leaks in the esophagus. The surgeon can close off distally, never proximal. And this way, we found now in even 10% of a patient a little bit of leak there. So even with the best quality of staples today, we induced in 5 up to 10% of the patient a little bit of leak. And I'm not worried, because the surgeon will then correct that, and thereafter we will check again if the leak is there. And I was telling then my surgeon, I prefer that I destroy your anastomosis instead of the patient doing it tomorrow. And due to that fact, we have in the last 3 years, we have no leaks anymore in the gastric bypass procedures, because we are really heavy stretching these aspects. And then we always do then a control again to check it. You see the position of the gastric tube to be right. Then we will inject again the same amount of fluid, and there, as you can see now, there's no leak anymore. It's not only the staplers that can be a trouble. As you can see here, it may be also the surgeon who was, well, touching too much the adventitia, and we would not see that if we didn't do a leak test. The staples are perfect, but there's some damage done here for whatever reason above the staple line, and we would not be aware of that. Now, this is not a disaster. We will do some closure again and test each time again. So this is not happening that much indeed, but if you even have one patient in 100, this is a disaster. You should absolutely avoid. That's for the leak prevention. Something what we look also to the color, because if there are areas that stay white suddenly in the revision surgery, this might be a reason for a late leak after a week, when there will be some ischemia. That's the other aspect we all do now is increasing the blood pressure. And there was the old study where we were looking to the systolic arterial pressure, and here you don't see anything. You would be safe and say we close, and we raised in the same patient the pressure, and a few minutes later you see an artery. The trouble is that the staples, the metal staples, they keep the arteries open and they prevent them from retracting. Normally, if you're sewing lines, you get always some kind of retraction, and after 1 or 2 hours, there's no risk anymore for an artery to start bleeding. But if you use staples, these arteries are kept open, they cannot retract, and that's the reason why you see, even hours after the procedure, still a risk when the blood pressure rises from an artery who starts to suddenly to bleed. And these are the spots we have to find. We put a clip on it, and that's it. You see, we raise the blood pressure at the end of the procedure. First, we do it by permissive hypercapnia, something we have to do already, using small tidal volumes. But even I lower my ventilation more to get even higher CO2, so the cardiocarbon rises, the perfusion increases. And sometimes it's not enough, then we'll add some ephedrine, phenylephrine. We'll not use fluid loading except if it's hypovolemia to get these higher pressures. And then it's easy to see these spots. But by having a clip here, we really prevent a postoperative disaster. A revision procedure, as we all heard about, revision procedures have a dramatic increase in mortality. On top of that, the surgeon is also doing some more dissection around the purse string, removing the large vessels. That's helping too in preventing that, but nevertheless we still see some bleeders, so we still have to do that. Now the intraluminal bleedings we don't see laparoscopically, so therefore we have to do some aspiration on the inside. We do that before the end of the procedure, once each time again, and if we see some red blood coming, we will not waken up the patient and repeat procedure, or ask the gastroenterologist to do a gastroscopy to prevent the intraluminal bleeding, something you wouldn't be aware either. And if we just look to our data, we have over the years have made 3 groups, 2,000 patients up to 2007, when we didn't do any blood pressure increase. From 2007 to 2010, when the staples were improved in quality. In 2009, we started to do that increase in blood pressure. So in the last cohort, all patients got a higher blood pressure during testing. And what we see here is that postoperative bleedings were 3% in the early group. That was quite high. We reduced it up to a little bit of 1%. So this is a fantastic improvement for us. This is all bleedings all together. So even someone who got a drop in hemoglobin is accounted as a bleeding. Now if we look only to the revisions, you see here we had, in the first period, we had 1% reintervention for revisions, and today this is extremely small. It's still probably there, but even in the reintervention surgery for reconstructive, and this is now getting 20% of our total load, we see no revisions for bleeding anymore. So again, it is that important to work together to get that improved. And I will end with with this, because otherwise we will have no more time to do some discussion on this item.
Okay, thank you very much, Jan.
Thank you very much.
Questions, comments from the audience? Yes, please.
Yeah,
There's a microphone in front of you.
Jan Hellenbrod, Sweden. I'm a surgeon to start with. The best communication between anesthesia and surgery is predictability in operative times, and it hasn't been mentioned here. But if you work with a team of surgeons with a standardized technique, the anesthesia can adapt, and they know exactly. Now they do this, it's 3.5 minutes to go until we do this, and then it's whatever. That has helped us enormously. We have monitored the exact time for each moment, each part of the operation, and now we have 100% predictability. So our anesthesia knows exactly when to do what. We don't even have to talk about it, we just know.
Yeah, but it's important, absolutely, that we know each other. It is in both directions. It's the same that you as a surgeon know exactly what we have to do, how much time we need for some preparations and these aspects. And nevertheless, we have to still to communicate, because there are things changing in your area, there are changing things in our area, and we have to communicate that to each other. And we have also to explain the problems we still have, what we still see. So I'm happy when my surgeons say, well, look, there seems to be an increase in pneumonia or whatever, what's going on, let's check for that. So it is that important. So I've also been looking to the numbers of bleeding and revisions to be aware if we would do something to improve that.
Any other questions or comments? Okay, yeah, thanks very much. We have some time at the very end, so we'll catch up.